So the International Society for Heart and Lung Transplantation defines heart failure as a clinical and pathologic syndrome that results from ventricular dysfunction, volume or pressure overload, alone or in combination, leading to characteristic signs and symptoms such as poor growth, feeding difficulties, respiratory distress, exercise intolerance, fatigue, and is associated with circulatory, neurohormonal, or molecular abnormalities. Pediatric heart failure differs from adult heart failure mainly due to the variety of etiologies, generally classified into three: heart failure due to cardiomyopathy, heart failure due to congenital heart disease, either with biventricular or univentricular physiology, or heart failure from acquired heart disease. Pediatric randomized clinical trials are scarce, and we are left with consensus-based recommendations for managing heart failure. This is just a slide which shows the clinical features of decompensated heart failure in pediatric patients. They usually present depending on the age, but most of them will present with tachypnea and tachycardia, poor weight gain, diaphoresis, abdominal pain, orthopnea, and fatigue. Much like the adult, the proposed heart failure classification for infants and children by the American Heart Association and the American College of Cardiology, there are 4 stages, stages A to D. Stage A with increased risk for developing heart failure. Stage B, those with abnormal morphology but no symptoms of heart failure. Stage C, those with symptoms of heart failure. And those with end-stage heart failure. This is just a slide of the different etiologies for heart failure in a different age group, but you will notice that most of them can present with myocarditis, even in the fetal, the premature, or even the full-term neonate. And dilated cardiomyopathy is the most common myopathic process leading to heart failure in children. And the most common cause of acquired dilated cardiomyopathy is myocarditis. Chronic heart failure, much like the adult, is classified into 2 types. Your heart failure with reduced ejection fraction, commonly associated with dilated left ventricle with inadequate ventricular contraction, and your heart failure with preserved ejection fraction, primarily diastolic dysfunction with increased ventricular filling pressures with elevated atrial, venous, and pulmonary arterial pressures. The drugs that I will be discussing mainly address heart failure with reduced ejection fraction. The diagnosis of heart failure is an integration of clinical signs and symptoms and diagnostic tests. The chest X-ray may show cardiomegaly, increased pulmonary vascular texture, or alveolar edema. The ECG may show ventricular hypertrophy, rhythm abnormalities. The most important laboratory marker, which is often elevated and strongly correlates with the worst symptoms and the decreased ventricular function, is the proBNP. The fundamental exam for the diagnosis of heart failure in children, demonstrating dilatation of the cardiac chambers, systolic and diastolic dysfunction, and identifying the cardiac defects, would be the echocardiogram. This slide just shows the different stages with the different drugs that are recommended with the different doses. And diuretics, ACE inhibitors, ARBs, beta blockers are the recommended heart failure drugs for reduced ejection fraction in children. The standard inotropes includes epinephrine, norepinephrine, dobutamine, dopamine, and milrinone. Sacubitril, Valsartan, which is the first drug that I will be discussing, or Entresto. Sacubitril is an neprilysin inhibitor, while Valsartan is an angiotensin II receptor blocker. And the combination, or what we call the ARNI, is the angiotensin receptor neprilysin inhibitor. So this is the mechanism of action of Entresto. Basically, Valsartan, or the angiotensin II receptor blocker, is a RAS inhibitor. It decreases vasoconstriction, reduces sodium and water retention, and reduces hypertrophy and fibrosis, which leads to ventricular remodeling. Your neprilysin inhibitor results in increased vasodilatation, increased natriuretic diuresis, and it also reduces hypertrophy and fibrosis, therefore improving ventricular remodeling. The indication for Entresto is the treatment of symptomatic heart failure with systemic left ventricular systolic dysfunction in pediatric patients aged 1 year and older. It reduces NT-proBNP and expected to improve cardiovascular outcomes. In children, there is a starting dose of 1.6 milligram per kilogram and titrated every 2 weeks until the maximum dose is reached. Entresto is given twice a day, and the doses are based on the weight and age and titrated every 2 weeks. These are among the side effects of Entresto. And because of that, it's contraindicated in pregnancy because of the possible fetal toxicity. Contraindicated with those impaired with renal function because this further increases serum creatinine. In patients with hypersensitivity to any of the components, or those with a concomitant or side effects with ACE inhibitors. Likewise, because it causes hyperkalemia, it is watched out for in patients with being given potassium-sparing diuretics, and it's contraindicated in patients with being given NSAIDs, as this can cause worsening of renal function. In October 2019, the US FDA approved this drug for use in children, and the approval was based on analysis of the 12 weeks from the 52 weeks panorama heart failure trial, which demonstrated reduction in the cardiac biomarker NT-proBNP in pediatric patients 1 to 18 years old with heart failure due to systemic ventricular systolic dysfunction. Entresto, according to the proposed 2024 IAS-HLT guidelines for children, ARNI is now a reasonable alternative to ACE-ARB. This is a class 1A level B evidence. The second drug that I'd like to discuss is Levosimendan, which is an inodilator for intravenous use and is an alternative treatment for decompensated heart failure unresponsive to conventional inotropes. So this is the mechanism of action of Levosimendan. The principal pharmacologic effect are it increases cardiac contractility by calcium sensitization of troponin C. It results in vasodilatation, resulting in decreased pulmonary capillary wedge pressure and decreased systemic vascular resistance. There is mitochondrial mediated cardioprotection. It increases glomerular filtration rate without significant increase in cardiac oxygen consumption, and it also increases force of contractility in skeletal muscles. So what makes it different from the rest? Levosimendan enhances myocardial contractility but does not increase intracellular levels of cyclic AMP or calcium. It does not cause increased myocardial oxygen consumption. It opens potassium ATPase channels in myocytes and vascular smooth muscle cells. It results in vasodilatation and is cardioprotective. It reduces preload and afterload. It increases blood flow to organs, including the coronary blood flow, and therefore it has anti-ischemic effects. This graph just shows the characteristics of an ideal inotropic agent, comparing dopamine, phosphodiesterase inhibitors. Levosimendan seems to mirror more the ideal inotropic agent. Levosimendan is used for short-term treatment of acute decompensated heart failure where conventional therapy is insufficient. The loading dose is usually 6 to 12 micrograms per kilogram over 10 to 30 minutes, and continuous infusion is given at 0.05 to 0.2 micrograms per kilogram per minute, and the infusion duration is usually up to 24 hours. Levosimendan is well tolerated with most adverse effects being dose-related, arising from the vasodilator action of the drug. In order to avoid hypotension, it is prudent to temporarily stop vasodilators while administering this drug. Likewise, it can cause prolongation of corrected QT interval and really ventricular tachycardia, and should be avoided in patients with these problems, and also avoided in patients with torsade. Among the contraindications will be hypersensitivity to Levosimendan or racemic semendan, and it should not be used with those with severe renal or hepatic impairment, those with severe hypotension and significant tachycardia, and those with significant mechanical obstruction affecting ventricular filling or outflow or both. Caution should also be used when patients have a rhythm disturbance or potential life-threatening arrhythmias, coronary ischemia, long QT interval regardless of etiology, or any medicinal products like your macrolides that can prolong the QTC interval. Likewise, you should correct hypovolemia as this can cause further hypotension in patients. The effects of on the blood pressure generally last for 3 to 4 days, so that you need to continue non-invasive monitoring for at least 3 days after the end of the infusion until the patient is clinically stable. Hepatic dysfunction may lead to increased concentration of the metabolite. Therefore, we try to screen for severe hepatic dysfunction. It may also cause decrease in serum potassium concentration so that you can monitor the electrolytes as needed. It can also be accompanied by decreases in hemoglobin and hematocrit. And so you use this with caution in ischemic cardiovascular disease and those with significant anemia. This is just one of the trials that compares Levosimendan and dobutamine, the LIDO trial. And the conclusion is among patients with severe low output heart failure, Levosimendan was associated with an improvement in hemodynamic response at 12 hours and a decrease in mortality at 180 days when compared to dobutamine. In the casino trial, or the calcium sensitizer or inotrope or none in low output heart failure patients, dobutamine was associated with lower 6-month mortality compared to Levosimendan or placebo in patients with decompensated low output heart failure. In conclusion, management of heart failure in children often mirror therapeutic strategies validated in adult population. The parallel is drawn out due to the paucity of pediatric-centric clinical trials. Most treatment rely on consensus-based recommendations within the International Society of Heart and Lung Transplantation pediatric guidelines. Future pediatric heart failure guidelines will evolve primarily from safety and efficacy studies of established treatment in adult heart failure. The challenge is to come up with pediatric heart failure trials despite the limited patient cohorts, diverse etiologies of pediatric heart failure, and complex pathophysiology in these patients. These are my references. These are the residents who helped me with the slides. Thank you very much.